name is Addie. I am a psychology resident here at UCLA in the Pediatric Consultation Liaison track. So I spend most of my time in the inpatient PEDS units, the PICU and the PEDS floor at Ronald Reagan. And I'm a fifth-year doctoral candidate at the PGSP Stanford Society Consortium. And there we go. So I'm not 100% sure how much familiarity you all have with child psychology at this stage in your training. So I tried to make it kind of broad, but also as relevant to dentistry as possible based on my knowledge. So hopefully that can be helpful. And I provided some resources too. So at the very least, you kind of know where to go if you want to refer to some of this again, if it comes up. So really for today, I just wanted to go through some of the current research, just to familiarize you with kind of what's going on with mental health in our country and across the globe with kids. Talk about underserved populations, gender minorities, talk about how to screen and assess for mental health concerns in other healthcare settings, so primary care or even potentially in dental offices. We'll talk about what to do if you have an acute concern over somebody's mental state, and then we'll go over some of the primary things that are, I think, most likely to come up in dentistry in terms of just mental health needs for kids. So just to kick us off, here's just a very broad definition of mental health. This is the CDC, so it includes our emotional, psychological, and social well-being, influences how we think, feel, and act, and helps us determine how we manage stress, connect with others, and make healthy choices. So very broad, but it just kind of speaks to the fact that there are many different facets of mental health and how our psychological and emotional states affect our behaviors. All right, so here is the current state of research, some of it. So we can start more broadly talking about like specific diagnoses. So in terms of prevalence, 1 in 6 kids, so that's from ages 6 to 17 in the US, are experiencing symptoms that are clinically elevated. So that would include ADHD, behavioral problems, depression, and anxiety. And then globally, it's a little bit less. It's about 1 in 7 kids are experiencing those clinically elevated symptoms. When we talk about risk factors, so I'm just going to kind of talk about suicide broadly for risk, because ultimately that's, I think one thing that providers should be most aware of. So risk for suicide increases with age. So as somebody gets older, they have more access to means, but also there's more time for the effects of, a mental health condition to kind of set in and kind of morph over time as well. So age is a big risk factor, as is poor health, physical health, and poor caregiver mental health. So parental involvement is pretty huge for kids. We also can see that depression and anxiety has increased significantly over time. So it went up about 3% from the years of 2003 to 2011. And some stats have showed that these rates of anxiety and depression have doubled during the COVID-19 pandemic as measured through like primary care settings. The research like kind of has a wider range than that, but regardless, there's been a very significant increase. And that could also be because, kids that normally wouldn't necessarily have as much access to primary care now with the pandemic are going into doctors' offices and then are getting screened. But clearly there's also a lot of social isolation and other, psychosocial factors that have affected kids during COVID-19. And when we talk about suicidality, there's been a significant increase in the past 10 or more years. It is now the second leading cause of death for young people, which really speaks to the state of mental health and treatment in our country. And as far as treatment goes, even, those who are kind of identified in primary care, still about half of all children with mental health disorders in the country don't actually get treatment at all. This varies per state, and varies by disorder as well. But even those who do end up getting treatment can have a really long delay between the onset of symptoms and intervention. So that'd be like 8 to 10 years on average. So there's a lot of time for there to be some pretty negative effects of a mental health condition within that time period. So it's obviously extremely important to not, generalize the statistics here. So we should really break it down and look at race and ethnicity as well, and how that affects kids' experience of mental health. So racial and ethnic minority youth are more likely to receive fewer services, but also worse in quality services than their non-Latino white peers. So when we think about that, we can look at the effects of racial discrimination, limited access to care in underserved areas, as well as some cultural difference in the acceptance of mental health treatment. So, the likelihood that a child's family is going to actually seek out or agree to treatment can vary as well, and kind of inhibit at times treatment. Of all youth, multiracial youth are at the greatest risk for severe depression. More than 1 in every 7 multiracial youth met criteria for depression in severe depression in a recent study. And minority youth are also more likely to drop out of treatment. And white youth who have depression also are more likely to receive treatment, as we kind of talked about earlier. So there's an interesting breakdown of the treatment availability by race. So actually, in the US, Asian youth are the least likely to receive treatment, followed by Latinx youth, then Black youth, multiracial youth, and then white youth are the most likely. And if you think about why these disparities exist, there's lots of different things, as we kind of talked about a second ago, but we want to pay attention to compounded community trauma and exposure to violence in underserved areas, repeated experiences of discrimination for kids in various different settings, chronic exposure to racism. There are a lot of very specific risk factors that these kids are dealing with, and therefore experiencing higher rates of mental health concerns. Among kids whose families are low income, more than 1 in 5 had a mental health disorder. So it's actually greater than the 1 in 6 that we were talking about for the more general population. So more likely to have a mental health disorder for kids who are low income. And again, this is just impacted by the factors we discussed. So like stress from the environment, greater likelihood to be exposed to community trauma. And there's an interesting study that found that subjective social status is actually the most associated with kids' mental health. So it's a child's perception of whether or not they are better off or worse off than their peers, not necessarily if they actually are better or worse off. And even when kids are able to receive treatment that are, members of racial and ethnic minorities, there's almost no literature on treatment preferences among minority youth and families. So that would look at like cultural and familial values in treatment options, which is a huge problem. And that's why we have really high dropout rates for minority kids. They're more than twice as likely to drop out of the therapy because there may not be the therapeutic relationship there if, that discussion or effort to tailor treatment to an individual's culture is not taken into consideration. So the question is then, what can we do with this information? And the answer is we don't have an answer, but part of it is that we can implement assessment instruments into healthcare settings to try and screen for kids who might have some sort of mental health concern. We also definitely want to like research the validity of the assessments that we're using and make sure they're, accurately representing the experiences of BIPOC youth. And also remote care is a really great way to increase treatment accessibility, especially for families who are maybe in more rural areas. All right. So I did want to talk about gender and sexuality. This is a big clinical interest of mine, so I have to throw it in any lecture. But for just in general, when we're talking about mental health, we do see some gender and biological sex differences. So studies have shown that youth whose biological sex is male, they're actually more likely to have a mental health disorder when they're very young, between 2 and 8. But overall, as kids get older and we look at the greater picture, females are actually more likely to have depression and anxiety. And the LGBTQ plus population is more than twice as likely than cis population to have depression and anxiety. And the really scary stat is that they're actually more than 4 times as likely to consider, plan, and attempt suicide than cis and straight youth. So it's a very high risk population and one that we need to all be pretty well versed in. So to put this in a perspective, it's estimated that at least one LGBTQ youth between the ages of 13 and 24 attempts suicide every 45 seconds here in the US. So using affirming language is key in minimizing gender dysphoria and feelings of marginalization and rejection. So for instance, there's been research that has shown that trans and non-binary youth who had their pronouns respected by people in their lives attempted suicide actually at half the rate of those who did not. So again, like affirmation where we can, and one just being like utilizing the correct pronouns and asking about gender identity and just trying to be sensitive before we assume anything, especially in healthcare settings, can really make a difference. This is just this isn't necessarily about healthcare providers. This is about families, but what you can see is that there's a linear relationship here. So this is lifetime suicide attempts by an LGBTQ plus kid and perceived family acceptance. So, we're talking about like rejection. So if a kid has very high rejection from their family, they are much, much, much more likely to attempt suicide than those who are like don't have too much rejection. Their families are a little bit more accepting. But what's interesting about this is that it is a linear relationship. So it kind of indicates that obviously acceptance isn't an all or nothing construct. And by affirming youth in certain ways, so by using, as I said, like pronouns, using a preferred name, even that if it's like a nickname and not actually utilizing birth name, every little step can kind of count in helping us make sure that youth are less likely to attempt suicide. Obviously, this is most important with family, but I think it's also very relevant for healthcare workers as well, especially for kids to kind of establish a sense of trust in their healthcare providers. Okay. So I know that you all, or I think that you all had a lecture on adverse childhood experiences. So I won't go really into the signs and symptoms of child abuse in this lecture, but I did want to give some qualitative signs of emotional distress and risk for suicide, as hopefully it might be helpful in your practices. So when you notice self-harm, so cutting or burns, or skin picking as well, that's not as much self-harm, but once you notice like self-inflicted wounds maybe on a patient, I think sometimes there's some confusion as to what that can mean. And so it's good to kind of parse out what that possibly could be indicating. So research has shown us that youth who do self-harm are at greater risk for suicidality, so attempting suicide or expressing suicidal thoughts. So about 65% of kids who do self-harm will be suicidal, but it's important to consider the attempt. So the intent of the self-harm. So most of the time, it's actually not an actual attempt at suicide. It's more to get like a sense of emotional release. For some kids, it's a way to kind of engage in self-punishment, generally just a way for kids, who don't have another outlet to try and feel better as opposed to actually ending their life. But there are some things that can kind of attenuate this relationship between self-harm and suicide. And so factors that can increase someone who self-harms can increase their risk of having suicidal thoughts are family conflicts, self-harming for more than 20 times thus far in their lifetime. So up until 20 kind of depends on whether or not that really increases risk, but research has shown that like 20 or more is really when we should be especially concerned about risk for suicide. Other things would be recent psychological distress, a trauma history, impulsivity, substance use, diagnosis of depression and PTSD. So it's just a piece of data for us to keep in mind in conjunction with other factors, but on its own, self-harm isn't indicative of suicidal behavior necessarily. And when we're thinking about what would depression look like, especially in younger kids, it can look like chronic irritability and anger and not so much sadness. So this is why it can get really missed by providers and by families. Generally a lot of people will think this is more like a behavioral issue when it's actually, oftentimes a symptom of depression. So, other things that you might see for a patient coming into your office would be if somebody's tearful, if they're socially withdrawn, if they seem very fatigued, really poor hygiene, lots of somatic complaints. So not so much like complaints about what's actually going on in the procedure, but, oh, my stomach hurts really badly, or I have a headache. A lot of those can be actually symptoms of depression. And anxiety, at least in healthcare settings, it's a little bit more of a uniform presentation. So it would be kind of easy to spot in a lot of senses. Somebody might be fidgety, asking lots of questions of you, potentially sweating, asking for lots of breaks to go to the bathroom. These are all kind of telltale signs that a kid might be having some anxiety. So if you are genuinely concerned about a kid's mental state, first thing to do is build some rapport. You can't kind of go right straight to it and ask them what's going on. If you don't have rapport, you're not going to get a valid answer pretty much either way. So, do your best to build that rapport, ask about movies, their interests, shows they watch, music, video games, like just try and kind of establish some sort of relationship. But then you can be very direct when you ask about these things. I think a lot of providers get nervous and kind of like dance around the subjects. And, in these situations, it's okay to be like, to really ask about what the concern is. And then when we're talking about screening, so this is kind of the future of mental health care in primary care settings. So there's this big movement right now to infuse mental health into primary care settings more so. So I work at the adolescent medicine clinic here at UCLA, where we see a lot of kids who come in for we see kids who make appointments just for psychology, but a lot of the time it's other reasons. Somebody's coming in for a UTI, STD test, and we do a screener. We give them one of these screeners that I'm going to go over, and then you can kind of tell right away whether or not this kid needs to be seen by psychology. If so, then there's a consult that will be placed, and then hopefully that kid can be hooked up to care straight from the doctor's office. So that's kind of it's new in that it's much more valued right now, I think, especially with the pandemic. But this screening, how we do that is really important. We want to use measures that have been validated by the literature. And so some of those, I've picked some that are generally the ones that we utilize in primary care practice, but are also just like the most user-friendly, being the patient health questionnaire, the PHQ-9, which gets at depressive symptoms, the GAD-7, which is anxiety symptoms, and then there's the pediatric symptom checklist. I'll show you all of those in a second. But the best way to kind of introduce screening is just to frame it as something, hey, we do this with everybody who comes in the clinic. It's just for us to give attention to, things, your needs, things that you might not, or that you might want, needs that you might have. as opposed to, I think some kids can think of it as a little bit punitive. So research has shown the more you can normalize it and make it about the patient and their needs, the more that they'll be responsive to it and be honest as well. And the thing is with these screeners, you can't just give them and then have that information and not do too much with it. So it's only really helpful if you do have follow-up. So based on the level of risk, if I'm thinking about a setting such as a dental office where, this isn't necessarily what a parent might have in mind when they're coming in here with their kid. But if they are screened in this case and are found to have pretty significant symptoms of depression or anxiety, you want to think about if it's enough to share with a family member of the kid. So if kids are over 18, you actually have to ask their permission. And if they say no, then you can't actually speak to the parent about it. But it's kind of clinical judgment. If you genuinely are worried about a patient's well-being in healthcare settings, you would want to go ahead and have a meeting with the parents and the kid just to make sure that everybody is aware of what's going on. And that's more if it's passive, say we're thinking about suicidal ideation or something that's more like passive suicidal ideation. We'll talk about active and what to do there in a second. But you also would want to give resources for therapy providers. So I'm going to give a resource at the end for how to find Medi-Cal therapy providers. If you haven't, it's called Using Beacon. I don't know if that's something that you all use, but it's good to just have that knowledge so that when kids come in and are screened, if it is necessary, you can give them a little bit of information, let them leave having something in their hands, which can make a really big difference. It depends on the level of risk again, but if somebody is like scaring you a little bit, you can give them crisis lines, which I'll also provide at the end. And one of the big things you can always tell your patients, if nothing else, is if you're ever feeling unsafe and you don't know what to do, you can walk into any urgent care or any hospital at the ER, and they'll help you out with your mental health. Whatever that means, it's different for everybody, but I think it's helpful for some kids to know that, like, if they really just don't know what to do, if they're not feeling like their family is supportive in some way, they can just walk into an urgent care and know that they'll be taken care of. And then if you are, so say you give like the PHQ-9 for depressive symptoms and the patient endorses suicidal ideation, then you might want to give them another screener. This one's called the ASQ, the ASQ, and it's a really easy to use, awesome screener for suicide that I think is great for every healthcare provider to have in their office. So just as an example, this is the PHQ-9, depressive symptoms. The one that you really want to pay attention to, if nothing else, is number 9, which is thoughts that you might be better off dead or hurting yourself. And you can tally these up and technically, get an idea of what level are they at: mild, moderate, or severe depression. And these are what we use in adolescent medicine clinic as well. And then same with this one, it's the generalized anxiety disorder scale, GAD-7. Very straightforward, just asking about, basic core symptoms of anxiety. And then this, I think, is the most helpful one. Super user-friendly and really walks you through how to assess for suicidality. So like I said earlier, it's okay to be direct, and that's kind of what this reflects. So it really asks, have you wished you were dead? Have you thought about killing yourself? Have you ever tried to kill yourself? Instead of trying to use euphemistic language, it's best just to be clear with what you're asking. And this is great too, because it does give you ideas for the next step and where to go from there, which we'll tell you if something's acute or not. And then I'll also give you resources to these hotlines too. So highly recommend having this one available if you can. So if you are concerned, if say you've done that, the ASK questionnaire and a kid is endorsing active suicidal ideation or homicidal ideation, then you need to start thinking about a call to law enforcement. So forgive me if this is something you already know, but I'll go through it quickly. Section 5150 is technically what we can use with youth and with adults, but also with youth, to place somebody on a psychiatric hold, somebody who we think can't keep themselves safe. So the reasons that you would fall under the categories of this hold would be if you are an imminent danger to yourself, you can't like contract for safety, you're not sure if, hey, if I go home after this appointment, I'm not sure what's going to happen tonight. I could very well kill myself, or I have access to do so. Same thing for homicidal ideation. Surprisingly, we get more than you would think in terms of kids in adolescent medicine clinic who do have some homicidal ideation, generally towards family members when there's a lot of conflict in the home. Or if a kid is gravely disabled, which you likely wouldn't be seeing in the office, it's really if, this child is unable to take care of themselves, or family and parents aren't able to take care of their child and provide them with basic necessities due to their mental health condition. So if you are at this spot, you would call law enforcement, who can come over and assess the situation. And if they are found to meet criteria, then they can be put up to a 72-hour hold for evaluation and intervention from there. Okay, switching gears a little bit. So this is kind of some of the stuff that I think would be hopefully helpful in your settings, in your healthcare settings. Procedural anxiety, something I see all the time, every day in inpatient units at Ronald Reagan. And certainly something that in dentistry, I'm sure you see almost even more of. So just to kind of orient what is procedural anxiety, it's an excessive fear of medical, dental, or surgical procedures that results in very acute stress and might even actually interfere with the provider's ability to complete whatever procedure it is. So this could be a result of like compounded negative or uncomfortable experiences in a doctor's office, but even one single negative experience can actually lead to procedural anxiety and medical trauma. So, it's really important that we do what we can to, take care of the mental health of kids in the office, because again, even one poor experience can really like haunt them for a while. And we see that very often in the hospital. So for dentistry, especially, we know that the fear of dental procedures themselves, of the procedures themselves, is actually more of a problem than the pain itself. So you have a lot to work with, or a lot of work to do in terms of mitigating anxiety and behavioral outbursts and symptoms, things like that. So for example, procedural anxiety could be the result of a phobia. So like a needle phobia, for instance. So if you do have a kid with a needle phobia, there is one treatment that will work, and it is an exposure therapy, which is an outpatient therapy treatment. It's a type of cognitive behavioral therapy. That's the gold standard for any sort of phobia, and it's graded exposure to whatever the feared object or situation is under, pretty careful supervision and coaching with a therapist. So that's definitely a referral or a recommendation that you can give to a family if you do have a kid coming in with a pretty significant phobia. And so in terms of how we can like prepare best for the procedural anxiety, try and get like ahead of it. We want to do like a walkthrough of the procedure. Again, apologize if this is something that you all are very well aware of, but a good rule of thumb is to do a tell, show, do type of preparation. So you want to use kid-friendly language and tell them what's about to happen to them, then actually show them, and then you can actually do the procedure itself. But that's a way to really decrease risk for medical trauma and mitigate some of that procedural anxiety. And when you're describing, it's important too to use sensory descriptors. So, and ones that are developmentally appropriate. So instead of saying like, you might feel numb, you could say like, you'll feel like a pillow, or you'll feel like a cloud, or like a balloon, really giving them context, especially for the younger kids. And the thing about parents is parental, as I'm sure you know on your own, but parental presence can really, really help, and it's advised. And in the literature, it actually is very protective against medical trauma. So this is only the case if you have a parent who is able to control their own anxiety and actually be a source of comfort for the kid. But when possible, having the parent present can really help you out as well. And just limiting the number of providers in the room can also reduce the risk for medical trauma and lessen any sort of procedural anxiety that the kid might be having. So during the procedure and in the chair, what can we do to manage behaviors, especially anxiety? So reward systems are like one of the biggest things that we use in the hospital for behavioral management. They really work, but I'll talk about it a little bit more about it in a second, but very helpful to use throughout the procedure. And then another big one is trying to give kids choices as much as possible. So you're never going to say like, oh, can I do this? Or like, can we do this now or later? Like you want to be still very forthcoming with what you need, but still giving them choices where it's possible. So for instance, like, okay, which side of your mouth would you like me to start with? Which show do you want to watch? Just try and get as creative as possible with things to give kids that sense of agency. And you can also build rapport that way. But it really, really does help for procedural anxiety. And then distraction is a huge tool in our toolkit. So, obviously the types of media distraction in the exam room is super important. But you can also have, like fidget toys potentially at hand, or some sort of object that kids can really focus on and be distracted by. So, like fidget toy or slime, things like that kids can spend a lot of cognitive energy focusing on is going to be really helpful. All right. So a lot of my prior work has been in chronic pain management for kids. Acute pain management is very similar in a lot of ways, especially when we're just conceptualizing pain in general. So pain both causes medical trauma and makes it worse. It exacerbates it. So it's really important to manage pain so we can minimize that traumatic experience. So when we're monitoring pain, that is something we want to do for this very reason, but, and ways you could do that is like the FACES pain scale or a numerical rating scale, like 1 through 10. But you want to be careful. It's like a delicate balance because you don't actually want the kid to hyper focus on their pain and the painful experience. So, asking it at key points in time, but not constantly throughout, is going to be really helpful. When a kid is in pain, some coping techniques, or when they're just afraid also of being in pain, there are a bunch of coping techniques that we can use. So relaxation breaks, bubbles are a big one for kids. So by just like letting the kid, go into the hallway, if you have some bubbles that are available, it teaches them, like, it regulates their breathing. It actually helps them do some deep breathing. It also is a kind of a method of mindfulness because kids, again, can like get so focused on something like bubbles that it's their other cognitive energy isn't dispersed as much. So like, this is what they're focusing on. They're mindful, and it can kind of bring them back to a place where they're more calm and able to engage in the procedure. Another one that I really like is having a kid focus on parts of the body that aren't in pain. So for instance, I would say something like, okay, think about the very, very tip of your nose right now. Tell me everything that feels like. You could like prompt them to talk about like, what's the temperature? Is there a breeze that you can feel with your nose? Is it tingly at all? But you can do that with other parts of the body as well. Again, to just kind of divert the attention to a different part of the body and a different experience. Also just focusing on objects in the room. If you have, you could put something on the wall that has like a counting sort of game embedded in it. So like, okay, tell me how many ducks are up on the wall, and kids will, be able to kind of hopefully distract themselves that way. Thought stopping is something that I doubt you would technically use as much in your setting, but it is a coping technique that we can use for pain management. So for those kids who like hyper focus on their pain and start to catastrophize, they freak out, they seem excessively worried about their pain, you just advise them to think, like literally just think the word like stop. As soon as those thoughts come on, you can tell the kid to like say it out loud, like do some sort of like stopping motion. And then challenge them to think about something that's a little bit more positive. So something realistic can help too, like, okay, well, I'll have healthy teeth after this, or, whatever it is that will be the benefit of the procedure. Oh, I'm so sorry. Sorry. Feel better. Okay, and then another really important tool that we can use is imagery. So we want to think about imagining a favorite place for a kid, have them close their eyes and think about either a favorite place or a favorite memory. And what you want to do is go through all of the senses and have them describe to you what's going on. So this is a really powerful way of distracting from pain. So for instance, okay, you're on a beach right now, would be, oh, your family used to go to this beach, to Venice Beach sometimes. So close your eyes. What are you tasting? Like, what sort of food did they bring? What do you see? Do you have the sand in your toes? Describe that to me. Really try and get as descriptive as possible. And that's a way to relax and manage pain. So just some general tips on how to deal with pain, like not to downplay it. Parents can do this a lot, be like, oh, it doesn't hurt that bad. Come on, I know it doesn't hurt that bad. That actually only like further upsets the kid, and it doesn't really help anybody. Watch your verbiage. So instead of saying pain, you can use something like discomfort. That's a little bit more palatable. And, just reminding kids that this is temporary, and giving like a very realistic timeline, like, okay, in 5 minutes, this really, and be sure that you can kind of stick to that. Just be like, this will be over, and it will be over in 5 minutes. However, if you're off with that at all, you're going to lose rapport with your kids. So you just have to be pretty careful about that. But be honest and just let them know that, what's going on is temporary. This is just a way to teach kids about deep breathing, which is, a huge thing for pain management and for anxiety management, behavioral management. It's just deep breathing. A lot of research has shown that for people of all ages, this can really help regulate one's emotions and physiological reactions. So one that I really like with kids is balloon breathing. So essentially you have kids kind of put their hands on their belly and then have them inhale. And as they inhale, you'll do this with them, and you'll show that your entire stomach will kind of inflate. And that's what you want to do with deep breathing. You don't want kids to breathe up here in their chest. That actually has the opposite effect. But if you're breathing deep into your diaphragm, diaphragmatic breathing, that will slow down your heart rate. So to teach that with kids, you talk about inflating the balloon when you breathe out, and then show their belly, be like, oh, look at the like big balloon that you have, and let the air out. And you can have them do this a few times, kind of try and make it as fun as possible. But there are lots of different ways to go about this, as you can see, and you can find many more ideas online as well. And for older kids, really what you want to just show is, like, if your chest is going up when you're breathing at first, if that's the first thing that fills up, then you're doing it wrong. You just want to really inflate your belly, ideally in for 4, hold for 4, and out for 6, and then repeat that. This is a little blurry, but this is another one that I really like that you could have as a visual cue in your office. Star breathing. And so kids can kind of look at that as they're, as you're doing your procedure, and a kid is trying to breathe and you're like, okay, so let's stare at the star, like look at the star breathing, it's up on the wall, and you breathe in at the peaks of the star, and then you hold it and then you breathe out. And it's a way for kids to kind of like visually see how they're gonna do their deep breathing. This is silly, but I use this with little kids a lot. Just a YouTube video. It's a Sesame Street YouTube video on belly breathing. I'll just play it for a second just so you can kind of get the idea, but this is very developmentally appropriate for, I would say, like neurotypical kids up to age maybe 5 or 6. And yeah, we'll just give it a quick.
Hola! Today, I wanted to go outside and play with Elmo at the park. But my mommy and my papi said that I can't right now. It made me feel really, really frustrated. Yeah. Do you ever feel frustrated? Or sad or nervous? Yeah. Well, my mommy showed me a way to calm me down whenever I have big feelings or little feelings. It's called belly breathing. Hey, I can show you how to belly breathe. Okay, everyone, put your hands on your belly like this. Very good. Now take a deep breath in through your nose like this. And slowly breathe out through your mouth like this.
So yeah, you get the idea, but kids usually respond pretty well to this. Sesame Street also has another one too that's cute. So if you have, teens and young adults where obviously the Sesame Street isn't going to be quite as appropriate, but you do want to kind of guide them through deep breathing, you could even have this playing on their phone as you're going through the procedure. And this is, YouTube actually has snippets of the Calm app of some of the meditations. And it's nice because it has this nice like little landscape, but I'll play this for just a second. It's also great for providers if you want to take a second out of your day, and highly recommend you just download the Calm app or Headspace in the first place. But this is a nice way to just kind of center and relax a little bit, especially with teens and adults who are having a little bit more anxiety or pain throughout their procedures.
Welcome to this guided meditation called Long, Deep Breaths. My name's Tamara Levitt, and I'm the head of mindfulness at Calm. If you're not familiar with us, Calm is a meditation and sleep app that supports people to become healthier and happier. Meditation to relax your mind and body. Start by finding a comfortable position. Allow your back to straighten without tension. And allow the hands to rest on your knees or in your lap in an easy, effortless way. Close your eyes, releasing all tension from your face. Soften your forehead. Now to center the mind.
Anyways, I get tired when I listen to that, so I won't go through the whole thing, but again, that's helpful. Okay, I think this one hopefully will be useful for you all, but what to do when you have a kid who's having some behavioral issues. Sorry. Okay, hopefully that worked. And Jessica's in. Thanks for chatting me. So let's talk about some very specific things that you can do in your offices. So again, I said we would take a look at this reward system idea. They're super powerful. Again, I use them with a lot of my younger kids in the hospital. So what you want to do is you're setting yourself up for kids to meet positive goals that are reflective of positive behavior, and then you reward them from it, or for it. It's much more effective than being punitive or getting a kid in trouble or telling a kid what not to do. We really want to focus on the positive. So one thing you can do is have like a standardized list written down of like positive behaviors that you want to see from a kid in an exam or during a procedure. Show it to the kid ahead of time. And, let them know that there are incentives to meet these. So for instance, you could use a sticker chart, which I think is really helpful, with just little grids on it. And every time that they successfully do one of the things on the list, you put a sticker up. And then after a certain amount of stickers, or at the end of the visit, whatever it is, you let them choose a prize from the treasure box, or get creative with parents in a, way for them to provide. It's not bribery, but it is a way to encourage a kid to behave in a way that will be safe for everybody, which is most important. So some kids might just need the one incentive, like, okay, you can pick your treasure from the treasure box at the end. Like they feel good about that. They're going to try, really hard to behave throughout the visit. Some kids might need a little more incentive as time goes on. So you might want to, again, give them this sticker chart to show their progress and say, like, every time you get 3 stickers, you get to choose a prize or something like that. So again, it's like a really powerful tool and a really good way to positively encourage behaviors that you want to see. So we talked about this a little bit, but a caregiver's presence is protective, again, against medical trauma. Again, crucial that the parents are able to handle their anxiety themselves and are able to be comforting. If not, then they should not be in the room at all. So you should be like observant of the parent-child relationship at the very beginning of the visit to see if the parent is somebody who is kind of exacerbating the child's anxiety or feeding into it. And then from there, you can kind of make a decision whether or not you're going to ask the parent to step out of the room. So other behavioral management tips and tricks. You do want to avoid restraint, physical restraint, as much as possible. That's kind of obvious, but it really is something that we see as one of the main reasons for medical trauma. So instead, we want to like prepare kids ahead of time and use like positive incentive methods as much as we can. But, if need be, parents can kind of help to hold a kid's hand, have the kids like squeeze their hand. They can help support the kid's head if need be, but all of this should be done in a way that's not like restraining necessarily. But it's good to stop before the behaviors escalate too much to the point to where restraints would be necessary. So if you do have to take frequent breaks before you get to that point, then so be it. But getting to a certain point where they really do become combative or aggressive, everybody's kind of gone a step too far. At that point, it's way harder to reel them back in. And also like stopping what you're doing in the height of a panic, whatever it is, like an outburst, like stopping what you're doing and paying attention to the outburst at that time is only going to prolong the outburst because the kid's getting attention for it. It's not going to extinguish the behavior at all. In terms of like verbiage, again, labeled praise is a really big one. So when you tell a kid they're doing a great job at something, it's really important to be very specific. So I would say, for instance, like, really great job keeping your legs calm for the past couple of minutes. I love how calm your legs are and you're not kicking. Thank you so much for doing that. So even just saying like, you're doing great and good job, like, that's helpful, but that's not as helpful as telling the kid exactly what it is that they're doing a great job with so that they can then like repeat that behavior. You also want to be more cognizant about using, saying like, please do this, not don't do this. So if you're asking like, hey, please be still, please keep your legs still. Keep it, again, it's like a command right here that's like short, it's to the point, you're not asking too much of them. Please keep your legs still for the next 2 minutes, is much more effective than if you're going to tell a kid please don't move your legs for the next 5 minutes. You're also just pointing out the behavior that you don't want them to do, and then that's what they're focusing on. So focus on the positive behaviors, things that you want to see, not so much the things that you don't want to see. Okay, so here are some resources that could be helpful for you all specifically. I don't know if you've heard of the Trevor Project, but it's a really, really wonderful resource for LGBTQ plus folks. And it has a lot of stuff. It has like crisis lines, it has online community, it just has a lot of different like psychoed and resources. So if you ever want to kind of, you know, look up on some of this on your own, Trevor Project is a great way to start. Also, if you have a kid who, you know, you feel like could benefit from some further information or some community, this is a wonderful website for anybody. And again, I think this is what I mentioned earlier, but Beacon Health is a way to locate a Medi-Cal therapy, outpatient therapy provider. So, you know, if you do have a family and you do somehow screen and catch a kid who has passive suicidal ideation, isn't active, but you do want to make sure that they get linked up to care. Either you could send them to a trusted PCP, but that's also, you're not going to be guaranteed that there will be like a psychologist that's staffing. So you could just go onto this website. You could either provide this to the family or do it yourself. Go to Beacon Health and you just put in, you know, exactly what insurance, what type of Medi-Cal insurance your patient has and their address, and it will come up with a list of providers. But right now, all Medi-Cal providers are totally swamped after and during the COVID-19 pandemic. It's really hard setting my kids up in primary care with outpatient therapy. Wait lists are like 6 months to a year. So this one's tough, and you really just have to like look as well as you can, or like just really encourage parents to like keep trying and at least put a kid on the wait list. Like that can't hurt. At least they'll get some help at some point in time. And yeah, these crisis numbers, along with sharing with a kid that they can go to an urgent care and ER at any point in time if they're feeling unsafe, crisis numbers are kind of a must give for any kid who seems to be depressed or has suicidal ideation. So there's a text line, which is really great for some kids who don't want to speak on the phone. So you would just text home to 741-741, and you'll have a real person on the other end of the line who will text you and kind of do some crisis management. Obviously, the National Suicide Prevention Hotline. There's also an online chat through Dee Hirsch, which is kind of cool, again, for kids who like don't really want to talk over the phone, but maybe they don't have texting, you know, capabilities, whatever it is, there's also another option. And then for needle phobia, if you want to learn more about it or get more information on how to help your patients who have needle phobia, the Meg Foundation is really, really great. And they have a lot of information. They also just have a lot of general like chronic and acute pain information for kids. So that's a really great one. But yeah, if you kind of want to learn more and be able to like point a family in a direction for exposure therapy and have like a, you know, have more knowledge about what that actually means, you can check that out at the Meg Foundation. That is what I have for today. I was planning on only going about an hour because I want everybody to enjoy their Friday. It's in everybody's best interest, but happy to answer any questions that you might have about things that we talked about or any other just general peds mental health questions that you might have.
That was great. Thank you so much.
You're welcome.
Thank you so much.
No problem.
Thank you.
Enjoy your Friday too. Thank you.
Thank you.
Have a nice weekend.
Thank you, Eddie.
Of course. Thank you. Have a good weekend.
Thanks, you too.
Okay. Take care.
Bye. right, bye.